Colleagues and dear friends, we are now starting very soon our next webinar. And this webinar will be devoted to vitamin D. And we will have two speakers. One is Professor Andrzej Milewicz and one is Professor David Vàsquez. And I will start introducing Professor Milewicz and later on Professor David Vàsquez. Professor Vàsquez will do its own presentation in Spanish, but you will have the English translation also. Then, as I mentioned, the title of our present webinar is Understanding and Using Vitamin D. First presentation will be done by Professor Andrzej Milewicz, and endocrinology at University of Medicine in Wrocław and Karkonosze College in Poland. Former head of the Department of Endocrinology and Diabetology and isotope therapy, he is a specialist of internal medicine and clinical endocrinology and has held fellowship with the Danish and German Academies of Science and the Alexander von Humboldt Foundation. An internationally recognized expert, Professor Milewicz has served as a visiting professor at institutions including the Cornell Medical Center, University of Chicago, Columbia University, and University of Hamburg, and has been featured speaker at a major European and global endocrinology and gynecology conference. He serves on the boards of several national and international societies and is an honorary member of multiple scientific organizations. He also contributes to the editorial boards of leading in endocrinology and gynecology. And is also treasurer of the International Society of Gynecological Endocrinology. Andrzej, you have the microphone. Can you open your microphone? And then you can start your presentation.
Good afternoon, ladies and gentlemen. First of all, I would like to thank Professor Gerenzani for the invitation and give me the possibility to join his webinar today. The topic is really hard. I must say that 2 days ago I received a newsletter from American Endocrine Society, which was focused for aspect of vitamin D deficiency for our health. So today I would like to discuss the topic according to the vitamin D deficiency influence on obesity disease, prediabetes, and diabetes type 2. As you can see, the vitamin D is a group of fat-soluble vitamin crucial for bone health, immunity, and many other functions. The most important of which for human are ergocalciferol as well as cholecalciferol. The body can produce it itself in the skin under the influence of sunlight and obtains it from some food, but in the autumn, in winter period, supplementation is absolutely necessary to control our vitamin D levels. What we can say about vitamin D metabolism? First, the liver converts vitamin D from skin or dietary synthesis into 25-hydroxyvitamin calcidiol, which is the storage form and an indicator of body supply. Then, the kidney or other tissue performs second hydroxylation, creating 1.25 dehydroxyvitamin D, calcitriol, the most active hormonal form, regulating calcium and phosphate metabolism, as well as having a wide range of extraskeletal effects. So the very important role in the vitamin D metabolism play vitamin D receptor, which is located in all cells in our body, in all tissue, that explain the pleiotropic action of vitamin D, as you can see on that graph downstairs. So the deficiency of vitamin D can disturb cardiovascular system function, immune system, skin disease, cancer or tumor, muscle disease, intestine, as well as bone disease. So if you have a look for prevalence of vitamin D deficiency in Poland, so it's relatively high because 90% of healthy adult women and men in Poland present the deficit of vitamin D, lower levels than 30 nanogram per ml. So if you have a look for that map of Europe and Asia and it's too fast. Asia and Africa. So you can see that vitamin D deficiency depends on geographic localization. So the most aspect of, now not aspect, but the most causes of vitamin D deficiency is aging at first, pregnancy, impaired absorption of fat in the intestine and during the different disease. Also the influence of drugs like glucocorticoid, anti-epileptics and antiretroviral, and also low exposure of body surface to sunlight, including cultural and civilization consideration. So that's a graph presented data from a Paul Senior study where I was a coordinator in Poland. As this graph shows you how the vitamin D levels decrease with aging in women and men. So for that reason, so all people who are coming to the autumn of the life must absolutely supply, use the supplementation of vitamin D. So which clinical symptom can suggest us that we have maybe we have vitamin D deficiency? Tiredness, often of musculoskeletal pain, periodontal disease, loss of appetite, diarrhea, insomnia, visual disturbances, and bad taste and burning in mouth and throat. So when we can say exactly about vitamin D deficiency in our patient, so we can recognize in the blood levels of vitamin D is lower than 20 nanogram per ml. If the level is between 20 and 30 nanogram per ml, we can say hypovitaminosis. And over 30 is recommended levels. However, so if you have a look for literature, the best level most for our health is approximately around 50 nanogram per ml. So we also must determine parathormone as well as calcium concentration because it's strongly correlated and co-works with vitamin D. So approximately 1 billion people in the world presented low vitamin D levels. This paper, so we published in Polish Endocrinology in the end of the last year, and I was the first author. So we prepare the statement of expert from Polish Society of Endocrinology according to the rule of vitamin D deficiency in obesity, prediabetes, as well as diabetes type 2. We use several databases, as also we have some personal experience. So we focus, as I told you, how vitamin D deficiency is related to obesity disease, prediabetes, and type 2 diabetes. So according to vitamin D deficiency and obesity, it has several publications. And the first scientific paper which shows that levels of vitamin D is related to obesity was a paper published by Dr. Wartzman in 2000 with his colleagues. And then several papers support this observation. And recently it has been postulated that a non-genomic vitamin D receptor-mediated pathway may be the key target to the development of intervention for the treatment of obesity. If you have a look for this biometric analysis, suggests also that vitamin D deficiency is a storage of vitamin D in adipose tissue and impaired hepatic hydroxylation. Vitamin D deficiency in obesity is postulated also as a risk factor for hormone-dependent cancer. In summary, the above meta-analysis showed a significant association between vitamin D deficiency, obesity, and diabetes, and vice versa. So the very important role in the relation between vitamin D deficiency and obesity play vitamin D receptor. I told you that is we can find in all cell in our tissue in our body. This vitamin D receptor heterodimerizes with retinoid X expert receptor and binds to DNA and site vitamin D response element, which are located in the promoter region of vitamin D regulated genes. In the absence of ligand, this heterodimer form complexes with co-repressor and histone deacetylases, whereas in the presence of 1.25 vitamin D2 is recruit co-activators and histone acetyltransferases, leading to transcriptional activation. This genomic mechanism of vitamin D action via vitamin D receptor has a major impact on the biological effect of vitamin D on health and disease, particularly in obesity. So one way is genomic action of vitamin D, and the non-genomic action is characterized by very rapid second to minutes activation of signaling pathway involving phospholipases, phosphorinositase, protein kinase, and mitogen-activated protein kinases. Also, we must to say that vitamin D has also been shown to play a role in regulating the expression of certain microRNA, and that 1.25 vitamin 2 vitamin D reduce inflammation-related mRNA expression in adipocyte in vitro and in vivo study. So, what cause of vitamin D deficiency in aging people with obesity? So, the bibliometric analysis suggests that increased sequestration or dilution of vitamin D in adipose tissue, increased vitamin D catabolism in adipose tissue, and a reduced 25 hydroxylation also reduce sun exposure. So, also is very interesting observation, a paper published by Dr. Ben-Hur in Nutrients, which show as a different eating habits between obese and non-obese individuals with vitamin D deficiency. The difference is according to eating habits, sedentary lifestyle, dressing habits, decreased hepatic synthesis of vitamin D may occur as a result of secondary hyperthyroidism associated with obesity. The excess adipose tissue observed in obesity may provide a longer storage site for vitamin D, leading to low plasma vitamin D concentration. So, if you have a look for problems we can say about aging people, but how situation look in children and adolescents is a very elegant study, meta-analysis paper published in Frontiers Nutrition, including approximately 30,000 healthy children and adolescents, and the study show a very elegant relation between vitamin D deficiency and obesity also in children and adolescents. A linear relationship was demonstrated between the increase of vitamin D levels by 10 nanogram per ml and a 7% reduction of abdominal obesity during the treatment with vitamin D. So we know that obese people have hypertension very frequent. And this study show how high blood pressure is related to vitamin D. Also, it was found that, people with hypertension very often have vitamin D deficiency, and the treatment with vitamin D is as a supporting treatment to the other medicine used for hypertension is very helpful and give very good, better results that, like if you don't use vitamin D. So the other story is also very important, especially for women during the menopausal time. So the frequency of non-alcoholic fatty liver and mortality because of that disease in women now is higher like in men. A couple of years ago, the men show more frequent this metabolic disease. Now women have very often, and it's a very important point and risk factor for mortality. So as a vitamin D play a really important role in metabolic disorders, and supplementation give you very good results. So summarizing this part of my talk about vitamin D deficiency and obesity, so I must to say that the people with overweight and obesity, if women and men, presented much more frequent vitamin deficiency like people with normal weight. So for that reason, because also it was found that serum vitamin D levels decrease with BMI increase, an increase of BMI of 5 kilogram per square meter caused a decrease of 5 vitamin D levels by average of 5 nanogram per ml. So you must remember that if we start to supplement vitamin D in overweight or obese people, the dose of vitamin D must be 2-3 times higher, like in normal people with normal weight. So, in the second part, I would like to show you the data according to the relation between vitamin D deficiency and prediabetes. As you can see on the paper from 2006 from Dr. Hipponen and his colleagues, suggested vitamin D deficiency may affect glucose metabolism depending on body weight. Numerous studies have revealed a close association between vitamin D deficiency, glucose metabolism abnormality, and obesity, especially in children and adolescents. In 2009, several studies demonstrated an important role of vitamin D receptor in adipose tissue and its influence on energy metabolism and metabolism. So as you can see, the active VDR heterodimer with retinoid heterodimer binds to vitamin D response elements to induce change in gene expression that combine to improve its islet of Langerhans function, reducing insulin resistance. As you can see on that graph on the left side, you can see how vitamin D influence via vitamin D receptor for glucose metabolism, via influence for pancreas function, muscle function, adipose tissue function, as well of vitamin D liver function. So that's a very important spectacular graph which show you how important is vitamin D for our health. So vitamin D plays a significant role in regulating insulin action. Decreased beta cells function and mass may be due to increased inflammation, lipotoxicity, and glucotoxicity associated with vitamin D deficiency. The figure on the right side show illustrated conversion of 25 hydroxycholecalciferol to 1.25 dehydrocholecalciferol by 1 alpha hydroxylase and the vitamin D receptor transcript in the pancreatic beta cells instead of Langerhans. The active form of vitamin D promotes the human insulin gene and increase insulin production. So that's very elegant study published in Animals of Internal Medicine by Dr. Peters and his colleagues. So they compare how different dose of vitamin D, I mean cholecalciferol to 20,000 weekly, or cholecalciferol 1,000 daily, or L-decalciferol 0.75 microgram daily, compared with placebo in people with pre-diabetes. Vitamin D supplementation reduces the risk of diabetes by 15%. In adjusted analysis with 3-year absolute risk reduction for 3.3. Vitamin D therapy increased the likelihood, the regression of normal glycemic control by 30%. It's absolutely spectacular and very, very important for clinician information. Remember, if you have a patient with prediabetes, please check the vitamin D deficiency in your patient, because that gives you a successful treatment. There was no evidence in that paper of difference of even effects and adverse effects. But what is also very spectacular, the group who mean the serum levels vitamin D remained stable through the study around 50 nanogram per ml compared to the level 20 to 29. I mean the hypovitaminosis during the observation period. Cholecalciferol reduced the risk of diabetes by 76%. Got 76% reduce. It's a hot information, really, absolutely. Remember about vitamin D in pre-diabetes patient, obese. So in a meta-analysis published by Andrzej Justina and other experts in endocrinology and diabetology and endocrine review in 2024, so analyzing the several bibliographic data, so they show that vitamin D supplementation increase the likelihood of regression to normal glycemic control by 30% with no evident risk in people with prediabetes. Particularly as if the levels we have 50 nanogram or higher, so the reduction is approximately 76%. The other paper would show the same data like the paper before. Remember that. It's very information you can get with you at home. What we can say about vitamin D deficiency and diabetes type 2. So the vitamin D supplementation significantly reduced blood glucose, hemoglobin A1C, as well as HOMA index, fasting levels, in glucose levels, and also in patients with type 2 diabetes. When vitamin D was given in short time and in the big high dose, 50 nanogram, 50,000 units per 1 week, the vitamin D deficiency who were in overweight people or with hemoglobin A1C over 8%, so the therapeutic effect using this 50,000 units was the best. So that's other study, including over 100 patients with type 2 diabetes, show exactly the same correlation between vitamin D deficiency and diabetes. Also, the other paper done by Dr. Vàsquez meta-analysis suggests that vitamin D improves pancreatic beta cells function by regulating insulin secretion, protecting against inflammation, oxidative stress, and apoptosis. Specifically, vitamin D receptor in insulin-sensitive tissue, such as in muscle, facilitate glucose uptake and utilization, with some study reporting increased insulin signaling in muscle tissue, where most postprandial glucose uptake occurs. It was also by this author suggesting some genetic aspect of this these disturbances of vitamin D metabolism. So the others meta-analysis, including older people between 50 to 60 years old, actually with hypovitaminosis and type 2 diabetes. And now, if you have a look for this meta-analysis, hypovitaminosis could predict the occurrence of diabetes in prospective longitudinal study among older people. This graph shows you all publications which support this finding. They found to be associated with development of diabetes in older people, the vitamin D deficiency, even after adjustment for several potential confounding factors, confirming and updating the results of the only previous meta-analysis from 2017. So also come back to story about non-alcoholic fatty liver and vitamin D. The other paper shows this strongly correlation between vitamin D deficiency and non-alcoholic fatty liver. Summarizing this my talk, for the beginning, I would like to recommend you that if you have obese or overweight patient, please remember measure 20 vitamin D levels. Such is very important. It's very important for two reasons. The first one is the levels of vitamin D can give you the information how big dose of vitamin D supplementation you can use starting with treatment of the patient. And second one is very important because after 1 month of supplementation, you check again vitamin D, and then you can check if your treatment is successful or not. Because in the causes, if your patient have dysfunction of kidney on the liver, so the normal vitamin D, not active vitamin D, but metabolite of vitamin D, which we use usually, so it's not effective, and then you must start with active form of vitamin D for treatment. So, however, according to the dose, if the level is very low, between 12 to 15, what I must say, I have a lot of such a patient. It was my big surprise, also in young people. You can start using 20,000 units twice a week, or 50,000 units every 7 days. And after 1 month, you check again. And if the expected effect are not achieved, increase the dose or the replacement to calcifediol. If the patient have a problem with kidney and disease, also use the active form of, that's a graph of summarizing how, if your patient have vitamin D deficiency, how you can, what is the next step in the treatment. So, my dear colleagues, so I hope that I show you very clearly a relation between vitamin D deficiency and obesity disease, as well as pre-diabetes and the diabetes type 2, which is consequence of obesity, especially visceral obesity. Thank you very much indeed for your attention.
Thank you very much, Andrzej, for the beautiful lecture on the importance of vitamin D for diabetes and also to try to prevent diabetes. And then now we will move to the second presentation, which will be done by Professor David Vàsquez. And Professor David Vàsquez is a distinguished gynecologist, obstetrician, perinatologist, epidemiologist, and social security specialist based in Bogota, the beautiful Colombia. He served as professor at Pontificia Universidad Javeriana and is an honorary member of the National Academy of Medicine of Colombia. A recognized authority in menopause and climateric health across Latin America. He is the former president and honorary member of the Colombian Menopause Society and holds the Latin American Master in Gynecological Endocrinology, as well as recognition from FLASH-TEAM. Professor Vàsquez contributes internationally as a board member of the International Academy of Human Reproduction and is a member of the American Association of Gynecological Laparoscopy and a fellow of the American College of OBG, of Obstetrics and Gynecology. And David, you can share, you can take the microphone, you can share your slides, and you will present your lecture on another fantastic chapter of vitamin D. As you have seen, we are not speaking today as a whole of vitamin D, but on a specific chapter. Professor Milewicz won on diabetes, and Professor David Vàsquez will be on fertility and sexuality. Please, if you can share your presentation.
Thank you very much, Andrea and Professor Milewicz. It's a pleasure to me to be with this webinar. Do you hear me?
Yes.
Ok. Vitamina D y fertilidad es el tema. Entonces, primero entender que existen receptores de vitamina D en diferentes tejidos y órganos de la economía corporal que tiene que ver con fertilidad. Básicamente células de la granulosa, el cúmulo sóforus, la asidua, la placenta, el endometrio, las células epiteliales de las trompas de falopio y también en la hipófisis. En cuanto a la hormona antimuleriana, importante tener en cuenta esta hormona que es un marcador de las células de la granulosa de los folículos ováricos, actúa de forma independiente de las gonadotrofinas, desarrolla el folículo, es estable durante el ciclo menstrual y es superior a otros marcadores de reserva ovárica como FSH o inhibina. La FSH la usamos más como marcador de menopausia y la hormona antimuleriana como marcador de la reserva ovárica. Entonces la pregunta es si puede la vitamina D influir en la folículogénesis ovárica. Existe evidencia de que hay un efecto de la vitamina D sobre la expresión del gen de la hormona antimuleriana, pero los resultados son contradictorios. Una revisión sistemática del año 2020 habla de que los suplementos de vitamina D afectan los niveles séricos de hormona antimuleriana, pero tienen efectos opuestos según el estado ovulatorio de las mujeres. Se sabe que aumenta los niveles séricos de hormona antimuleriana en mujeres sin ovario poliquístico, pero los disminuye en mujeres con ovario poliquístico. En cuanto al éxito en la hiperestimulación ovárica, mujeres con síndrome de ovario poliquístico o infertilidad inexplicable, hay dos estudios, el PPCO2 y el estudio Amigos, que dicen que la deficiencia de vitamina D se asocia con riesgo elevado de pérdida temprana del embarazo. Es decir, el abordaje de la deficiencia de vitamina D forma parte del estudio. Recordar el factor masculino. Hay receptores de vitamina D en los tejidos reproductivos, tanto en hombres como en mujeres. Y en los hombres, estos receptores se encuentran principalmente en los músculos lisos del tracto genital, el tejido testicular y el esperma. De tal manera que en toda evaluación de fertilidad masculino debemos siempre pedir niveles de vitamina D, como ya lo dije, tanto en hombres como en mujeres.
Okay, we will do it in such a way, yeah? We will go to the, 1 second, we will go to the question, and I will ask Professor Milewicz, Andrzej, can you come? And then we will start with your question. And then later on, we will see what we can do with Professor Vàsquez. Okay, Denise Defi, she was asking, how does dressing play a role in vitamin D deficiency?
Once more?
Yes, how does dressing, how you are dressed, to play a role in vitamin D deficiency?
So I say it's a very difficult question. So of course the dresses eliminated the contact with sun. For that reason, so during the summer it's better if we would like to building via sunlight. Our vitamin D is better to eliminate it most of our garderobe to put a bigger part of our body to sunlight.
Thank you, Andrzej. And another question from an anonymous. What would be the balance between skin protection for sun effects, especially in countries under ozone holes, and receiving sun in the skin for vitamin D generation? Are special part of the body more important for this?
No, the part of the body it's not important because our skin in our whole body can produce vitamin D, and I think that is better protect our faces, especially because it's as the sunlight make our skin more aging like normally. So it's better to put our arms or chest for sun.
Okay, and then another question now. In a female 80 years old with osteoporosis and Crohn's disease, which is the dose of vitamin D supplementation, and how often is important to test the level of vitamin D?
So the important things, it's difficult to say that it's for Crohn's disease. It's no special dose for vitamin D for Crohn's disease. So we can propose vitamin D treatment according to the vitamin D levels in the blood. And then so we can control, as I told you, after 4 weeks, again, the vitamin D levels. If it's okay between 30 and 50, that's okay. And so we can continue the treatment. Usually, if we have a normal range of vitamin D, the supplementation for obese people can be 4,000 every day.
Thank you. And now Nelly Bozaire, she have a question. How for you? What is the role of vitamin D3 depot injection for this patient, especially for improving treatment compliance? And also, is there any evidence regarding effect of vitamin D on hypercholesterolemia and vice versa?
It's for sure it's a positive influence for hyperlipidemia, the vitamin D, as I told you, because if you have a positive influence for glucose metabolism and also the other metabolic aspect in our body, so it's influence also positively and for the profile of lipid and hyperlipidemia.
And then another from Elena Rota. It is true that a daily supplementation is more useful than a weekly supplementation regarding the improvement of the immune system.
So as I showed you during my presentation, so in obese people and with very low levels of vitamin D, between 10 to 20. So I recommend high dose of vitamin D for treatment, 20,000 2 times a week or 50,000 for 1 week, because as the publications show, the effectiveness of the treatment is very good, and that's a fantastic group for positive response to vitamin D treatment.
Thank you. And then also Maria Udovishenko, she asked again, do sunscreen creams block vitamin D production?
So I'm sorry, I'm not producer of sunscreen. So it's for sure it's protect, absolutely, because if it's written on this information that is protect, so it means that protect. So if you would like to building the vitamin D, we cannot use a sun protector.
Thank you. And then now another question from Natalia Cherkasova. Thank you for very important information. The question, what doses per day you recommend for pregnancy, and its constant dose or different each trimester?
So it's many thanks for your very important question. Usually, so the most gynecologists recommended supplement for pregnant women, which including about 2,000 units of vitamin D. So in my patient, and not only in my patient, but I also recommend you, if you have a pregnant woman, please check vitamin D levels, and depend of the levels. If the level is over 30, so you can use only supplement with 2,000 units of vitamin D. But if the level is 15 of 20, please, so you must use supplement normally, but extra also plus vitamin D 2 or 4,000 to make the vitamin D higher, between 30 and 50 nanogram per ml. It's very important because low vitamin D levels is a risk for miscarriages, you must remember, and also some other complication during the pregnancy. For that reason, so supplementation, which we are using, are very important. But we must remember that most, especially obese women, pregnant women, present really serious vitamin D deficiency, and they need some extra vitamin D treatment. Thank you for your question. It's very, very important.
And thank you. Now we have still another from Verna Brooks Mackenzie. What is the recommendation for vitamin D daily intake in postmenopausal women who are not obese or overweight?
Usually all international statements recommend 4,000 per day.
And then also another from the other end of the world. Do people in India, where it is extremely hot, need extra time to sit in sun, or 6 hours sun are sufficient?
So you can, your production by your skin of vitamin D is very individual. So you must check the vitamin D levels, and then depends of the results. So you decide if you need some supplementation or not.
And then from Selma Abdellawi, is there a relationship between the serum lipid profile and deficiency of vitamin D?
This serum, yes. So it is some data which show the correlation between vitamin D and the lipid profile, as well as insulin and glucose.
And then another anonymous, if you give in osteopenia calcitriol, should you measure 25 hydroxyvitamin D or 125 hydroxyvitamin D?
So no, the first one is okay.
Thank you. And then from Susanna Nizhanska, if we have obese adult patient, is it reasonable to adjust dosage of vitamin D supplement due to the real weight?
I'm sorry, can you repeat this question? I'm sorry.
If we have an obese adult patient,
Yes.
it is reasonable to adjust the dosage of vitamin D supplement to the real weight?
So that's usually, so we are using 2-3 times higher dose of vitamin D in comparison to the people with normal weight. So it's depend what is the levels in your obese patient, and then so if you have the levels between for example, 10 or 12 nanogram per ml. So I recommend you 50,000 units every week. And then after 1 month, please check one more serum vitamin D levels. And then so you decided that you can to the dose changed, or you can continue. It depends on the effectiveness.
Thank you, Andrzej.
Estoy listo, Andrea.
Now,
Creo que estoy listo.
Professor Vàsquez, are you ready? You can go on.
Yes, I'm ready. Estábamos en el tema de vitamina D y fertilidad del factor masculino. La deficiencia de vitamina D se asocia con mala calidad del semen, bajo conteo de espermatozoides, alteraciones de la motilidad y morfología anormal de los espermatozoides. En cuanto a la inyección intracitoplasmática de esperma, este es un estudio randomizado doble ciego, controlado con placebo, en la cual se observa a la izquierda la comparación de la tasa de embarazo químico medida por gonadotrofina coriónica en el grupo de vitamina D y en el grupo placebo, y a la derecha del embarazo clínico. Como se ve, existe una diferencia clara entre los niveles de vitamina D y la posibilidad de éxito entre embarazo químico y embarazo químico y clínico. La conclusión es que el consumo de vitamina D durante 6 semanas antes del ICSI mejora la calidad del endometrio y la tasa del embarazo. Este es otro estudio midiendo el valor medio de vitamina D y relacionándolo con el número de ovocitos, los ovocitos fertilizados y el grosor endometrial. Y la conclusión es que la deficiencia de vitamina D dificulta el logro del grosor endometrial óptimo requerido para la implantación del embrión después del ICSI. Esta es una publicación en la cual se evalúan los efectos de los niveles de vitamina D sobre el grosor endometrial y los parámetros de crecimiento del folículo en mujeres que van a ser inducidas en la ovulación. La conclusión es que hay una deficiencia de vitamina D es directamente responsable de una reducción de la fertilidad y capacidad de reproducción, y que las mujeres con mayor nivel de vitamina D en el suero y en el líquido folicular es más probable que queden embarazadas. Actualmente está corriendo el estudio SUNDRO, que es el acrónimo de la suplementación de vitamina D y los resultados reproductivos. Es un estudio multicéntrico. Se aspira a tener 700 mujeres que están siendo sometidas a fertilización in vitro, y el punto de corte son 30 nanogramos por mililitro de vitamina D, como los niveles. 600.000 unidades versus placebo en una sola administración oral. Este estudio está corriendo actualmente. Esta es una publicación también del 2020 que relaciona la vitamina D como un nutriente importante involucrado en múltiples procesos de salud y en cuanto a fertilidad, con ovario poliquístico, con miomas, con calidad del ovocito, del semen, la calidad del endometrio adecuado para la implantación. ¿Qué tenemos de nuevo en este tema de fertilidad y vitamina D? Esta es una publicación del 2024 cuyo objeto es determinar la influencia de los niveles séricos de vitamina D en los resultados perinatales y de reproducción asistida en jóvenes sin ovario poliquístico. Es un buen número, 3.397 mujeres. El punto de corte es 20 nanogramos por mililitro, y la conclusión de esta publicación es que el grupo con deficiencia de vitamina D obtuvo una menor cantidad de ovocitos que el grupo sin deficiencia, y además una mayor prevalencia de diabetes gestacional, lo que sugiere que la deficiencia de vitamina D Afecta los embarazos asistidos y los resultados perinatales en mujeres infértiles sin ovario poliquístico. Como siempre, recomiendan más estudios para confirmar estos hallazgos. Esta es una publicación del 2024 que analiza la relación entre los niveles séricos de vitamina D y el número de ovocitos recuperados después de la estimulación ovárica, punto de corte 30 nanogramos por mililitro, y la conclusión es que no hubo diferencias entre el número de folículos, los ovocitos recuperados y los ovocitos maduros después de la estimulación ovárica según los niveles séricos de vitamina D. También en el 2024 sale esta publicación con el objeto de investigar el papel de la reserva ovárica en la asociación entre los niveles séricos basales de vitamina D y los resultados de las técnicas de reproducción asistida, pacientes sometidas y la conclusión es que la deficiencia de vitamina D no afectó los resultados del embarazo en la población general de pacientes, pero sí los afectó negativamente en mujeres con reserva ovárica disminuida, lo cual puede conducir a peores resultados del embarazo. Esta es una publicación del año pasado, 2025, cuyo objeto es evaluar la asociación del nivel sérico de vitamina D y la tasa de nacidos vivos en mujeres con embriones congelados. Son 1.489 mujeres, un número muy importante, que se sometieron a transferencia de embriones congelados. Y la conclusión es que la vitamina D no se asoció con una tasa de natalidad en mujeres con embriones congelados, no se observaron diferencias estadísticamente significativas entre los dos grupos. Esta publicación del año 24 para determinar si la vitamina D es predictor de fertilidad, y la conclusión es que sí se observó una deficiencia de vitamina D en las mujeres infértiles y que la deficiencia de vitamina D fue prevalente en todas las mujeres infértiles. Los niveles de vitamina D fueron predictor de fertilidad en esta población de estudio. ¿Por qué hay tantas discordancias en los resultados? Bueno, es probable que sea porque los grupos son heterogéneos, se usan diferentes dosis de vitamina D, diferentes esquemas, diferentes sitios geográficos y poblaciones que podría explicar esto. En endometriosis hay muy buena evidencia. Se sabe que la vitamina D reduce la interleuquina 1 beta y factor de necrosis tumoral alfa, que son sustancias involucradas en el proceso inflamatorio, y hay evidencia de que la vitamina D inhibe el reclutamiento de macrófagos en el peritoneo y disminuye la secreción de citoquinas. También en cuanto a OXA10, la vitamina D induce la transcripción del gen OXA10 y se encuentra una menor expresión de OXA10 en pacientes con endometriosis. Las células del estroma endometrial expresan receptores de vitamina D, expresan la enzima de 1-alfa hidroxilasa, igual que el endometrio ectópico. En cuanto a dolor, hay dos estudios interesantes, dolor en endometriosis. Uno, que se usaron 50.000 unidades semanales versus placebo por 12 semanas sin diferencias significativas, y hay que tener en cuenta que no dosificaron vitamina D en el suero. Y otro que muestra de 2.000 unidades día por 6 meses versus placebo, que tampoco hubo diferencias significativas, y los grupos mostraron placebo y tratado 31 y 33 nanogramos respectivamente. También hay algunos estudios sobre vitamina D y miomas uterinos, pero los resultados son disímiles. Igual la mayoría de los grupos recomiendan medir vitamina D en pacientes con miomatosis uterina. Un punto importante es el que tiene que ver con la sexualidad, la función sexual. Este es un estudio polaco publicado en el 2016, en la cual se observa que la vitamina D exhibe niveles más bajos en pacientes con scores más bajos también en el índice de función sexual. Esto es igualmente válido para los índices de síntomas depresivos, es decir, mujeres con bajos niveles de vitamina D tienen mayor expresión con diferencia estadísticamente significativa de síntomas depresivos. Y lo que es muy importante es que al suplementarlas mejoran tanto la esfera sexual como la esfera de síntomas depresivos en este grupo de mujeres. ¿Qué pasa con los hombres en la parte sexual? Existe evidencia de que la vitamina D en niveles adecuados exhiben mejores niveles de testosterona en estos hombres, y también el papel de la vitamina D en la disfunción eréctil ha sido demostrado. Y esto es apenas lógico, sabemos que la disfunción eréctil, que la mayoría es de origen vascular, pues está comprometido el endotelio de los vasos sanguíneos genitales masculinos y sabemos que la vitamina D a nivel endotelial ejerce un papel muy importante. Por tal razón, los niveles de vitamina D deben medirse en este grupo de pacientes con disfunción eréctil y puede ser una estrategia de bajo costo y de bajo riesgo para ayudar un poco en este tipo de problema. Este es un estudio de disfunción eréctil y vitamina D, disfunción eréctil de origen vascular, midiendo la vasculatura por medio del ecodoppler de pene, y la conclusión es que hay una significativa proporción de pacientes con disfunción eréctil vascular con deficiencia de vitamina D, lo cual habla nuevamente del papel endotelial que tiene la vitamina D en estos hombres con disfunción eréctil vascular. Entonces la pregunta es si la deficiencia de vitamina D contribuye a la disfunción eréctil, y nuevamente hago énfasis en que la mayoría de la evidencia que tiene la vitamina D sobre enfermedades vasculares y no vasculares se relacionan también con la disfunción eréctil en poblaciones masculinas, especialmente mayores. El doctor Milewicz habló algo de los esquemas de suplementación. Yo quiero simplemente ir al consenso colombiano de vitamina D que tuve oportunidad de liderar hace unos 3 o 4 años, y lo que sabemos o lo que el consenso estuvo de acuerdo es que la adecuada exposición solar es suficiente para mantener niveles de vitamina D normales en menores de 50 años y que la suplementación impacta favorablemente la mortalidad global en adultos. Una de las dificultades en los adultos cuya piel ya no sintetiza vitamina D a partir de la luz solar, por encima de los 55 o 60 años, es que el único alimento que nos puede dar la cantidad suficiente de vitamina D es el aceite de hígado de bacalao, que no es fácil de ingerir, no es muy agradable para ingerirlo todos los días. Y esta es una publicación de fertilidad y nutrición de vitamina D que habla de que la ingesta por debajo del nivel recomendado se asocia con menor posibilidad de concebir embarazos clínicos y nacidos vivos. El consenso colombiano recomienda una dosis básica de 1.000 unidades al día, en caso de insuficiencia de 1.000 a 2.000 al día, y en caso de deficiencia de 2.000 a 6.000 unidades al día o su equivalente. Y este es un estudio clásico de Chris Gallagher en relación con caídas, que habla de que la dosis de 1.600 a 3.200 unidades al día es la dosis ideal para reducir caídas en población mayor, independientemente de la raza de la persona. Finalmente, esta es una publicación de Wimalawansa del año 2024 que quiero compartir porque cada vez tiene más validez este concepto. Dependiendo de lo que nosotros queramos en los pacientes, debemos buscar los niveles de vitamina D. Me explico, si nosotros queremos función muscular, probablemente 20 nanogramos por mililitro sea un nivel adecuado. Pero si queremos impactar en osteoporosis, probablemente el nivel sea 30, que es lo que casi todos los consensos recomiendan, incluido el colombiano. Si queremos impactar cardiovascular, probablemente 40 nanogramos por mililitro sea un nivel mejor. Si queremos ya ir a sistemas inmunes, cáncer y COVID-19, que hay muy buena evidencia, 50 nanogramos por mililitro podría ser un nivel adecuado, y por encima de 50 ya tendría que ver más con psoriasis, enfermedades autoinmunes, esclerosis múltiple, etcétera. El consenso colombiano de vitamina D conceptuó que la dosis tóxica está por encima de 150 nanogramos por mililitro. En resumen, la vitamina D está involucrada en múltiples procesos biológicos, su deficiencia los puede alterar. La hipovitaminosis D se asocia con alteraciones en la fertilidad masculina y femenina. La hipovitaminosis D se asocia con alteraciones en la satisfacción sexual y en síntomas depresivas en mujeres, y la suplementación puede mejorar estos indicadores. En los hombres, la vitamina D juega un papel importante en la producción de andrógenos y la calidad del semen. La hipovitaminosis D se asocia con disfunción eréctil vascular,
y medir la vitamina D debe formar parte de todo el estudio en fertilidad y en sexualidad, tanto en hombres como en mujeres, y deben tratarse sus deficiencias. Entonces la pregunta es, ¿realmente es tan importante la vitamina D en la fertilidad y en la sexualidad? Y la respuesta es que sí, que es muy importante, y de tal manera que finalmente en ese invierno tan duro que están sufriendo los europeos, aquí en Colombia tenemos buen sol y afortunadamente decimos que viva el sol. Muchas gracias y ofrezco disculpa por las complicaciones técnicas que tuvimos en la presentación.
Gracias, gracias, David. Ahora vamos. Thank you, David. And now we will go back to the general discussion, as we have plenty of questions still for both of you. And I think I will make the question in English. Please, if you can, we will speak in English also with us. Okay. Then we have the question, and then I think we can start. Okay, we can start with a question. I think probably for that one for Andrzej, and from Sel Abdelawi. Is there a link between vitamin D deficiency and neurodegenerative diseases in general, and Alzheimer in particular?
It's not typical symptom of Alzheimer's vitamin D deficiency, as in most of the aging people. So we can expect it in people with Alzheimer vitamin D deficiency, but we must check. So it's no data that vitamin D deficiency is responsible for Alzheimer's disease till now, as I know.
Thank you. And then now a question for Andrzej, for David. Then ¿qué efectos qué efectos hay with the administration of vitamin D en pacientes con deficiencia ovárica prematura u baja respuesta ovárica?
Bueno, en pacientes con deficiencia ovárica prematura, obviamente lo importante es averiguar la causa de la falla ovárica prematura, pero no hay duda de que se relaciona con niveles inadecuados de vitamina D, y la falla ovárica prematura, parte del estudio que debe enfocarse es la medición y la corrección de los niveles inadecuados de vitamina D. Como ya lo mencioné en la presentación, la hormona antimuleriana también se relaciona con los niveles de vitamina D, y esto nos habla de que la vitamina D interviene también en la reserva ovárica, y en cualquier paciente, repito, que se vaya a someter a estudio de fertilidad, cualquier pareja, hombre y mujer, se deben garantizar niveles adecuados de vitamina D en ambos componentes de la pareja.
Thank you. Andrzej, there are several questions related to the fact what is the role of vitamin K and together with the vitamin D? Has a vitamin K an important role in the function of vitamin D?
No, so it's of course, if you have vitamin K deficiency, you can make supplementation, but that is not the fact that all people with vitamin D deficiency have also vitamin K deficiency. It's not necessary to make a supplementation of vitamin K if you don't have results of vitamin K in serum. But by the way, if I have now to say a few words more about vitamin D, which we don't discuss before, that I must so have personally experience with vitamin D deficiency in polycystic ovarian syndrome women. So we published paper which show that the vitamin D binding protein levels is lower, like HCBG in patient with PCOS, what causes vitamin D deficiency in PCOS patients. Remember, if you have in your practice patient with PCOS, please check vitamin D, and you can start with supplementation. And also remember about other autoimmune disease like Hashimoto disease or Graves-Basedov disease of thyroid, because in that patient you also can expect it because of autoimmune system, and so you can expect a vitamin D deficiency.
Yo quiero
Thank you.
anotar algo al
And then
respecto, Andrea. Quiero anotar algo al respecto. Uno,
Sí.
quiero enfatizar lo que dice el profesor Milewicz en el hecho de que toda mujer con ovario poliquístico necesita medición de niveles de vitamina D y corregirlos. Hay una clara asociación entre ovario poliquístico y niveles de vitamina D. Quiero recordar que el ovario poliquístico es una enfermedad sistémica, no es una enfermedad solamente ovárica ni ginecológica. Y por otra parte, si bien la vitamina K es importante, no es una condición esencial y sine qua non para administrar vitamina D. Me explico. Si el suplemento de vitamina D viene con vitamina K, está bien, pero no tiene que ser así. Se puede consumir vitamina D y suplementar sin necesidad de que tenga que tener vitamina K.
Perfecto. Y hay una pregunta, we have a question for you. What is about the role of vitamin D in the treatment of uterine fibroids and this potential to mitigate fibroid development and growth?
Sí, lo mencioné en la presentación. Existe buenas evidencias de relación entre miomatosis uterina, adenomiosis, que es una endometriosis intrauterina, y los niveles de vitamina D. Toda mujer con miomatosis uterina debe ser pesquisada para evaluar los niveles de vitamina D y corregir su déficit.
Andrzej, there is a question about the possible risk of hypervitaminosis D linked to the treatment.
Yeah, it's very important question. So yeah, I have a look for say my for patient for my practice. So I found a few cases with hypervitaminosis. Why? Because all media inform people how important is vitamin D, and most vitamin D in pharmacy, including supplement, which including different dose of vitamin D, not exactly the same what is written on the package, and also the people by themselves start to use extremely high dose of vitamin D to thinking that if they start with high dose, so they start to be more healthy and more younger. So for that reason, so it's very difficult, very dangerous topic, because if you start to create those over 100,000, 120 or 100 nanogram per ml, so you can have hypercalcemic problems, and with patient, which is danger for life of the patient. So that's you must start with treatment of vitamin D with consultation for your doctor. Don't do by yourself using only TV recommendation or some other recommendation.
Thank you, Andrzej. And then now a question for David. In patients, in infertile patients looking for pregnancy with insufficiency of vitamin D, what is the dose and how frequently we have to check?
Gracias. Una paciente o una mujer, más que paciente, que esté sometiéndose a consulta preconcepcional, idealmente debe tener niveles de vitamina D y estos deben estar por encima de 30 nanogramos por mililitro. Y si es una paciente de fertilidad con mucho más asiduidad, tenemos que medirle los niveles. Ahora bien, es bueno tener en cuenta que la dosis no tiene que ser diaria. La dosis puede ser diaria, semanal, quincenal, mensual. Básicamente depende de la comodidad para la paciente, pero no hay duda de que toda paciente preconcepcional, embarazada, por supuesto, y en estudio de fertilidad deben medirse los niveles de vitamina D y deben corregirse las deficiencias.
Y another pregunta es que, another question is, in those patients who were under treatment with vitamin D and they become pregnant, that is important to maintain vitamin D during pregnancy?
So I told you during my presentation that every pregnant woman must check the vitamin D levels, because the dose of vitamin D 2000, which usually so the pregnant woman using, sometimes is too small dose. For that reason, it's necessary, if the woman is pregnant, she must check, and then she use supplement plus medicine with vitamin D if the level is low.
Thank you. Thank you very much, Andrzej. Yes, but it was consistent. And then is another question. There is no concept from Elena Rota. There is not consensus on the supplementation of vitamin D in non-obese patients. 800 units per day is not sufficient.
800 units is too small dose. Even the all international statement recommended 2000 at least during the whole year. Also for adult people.
Thank you. And then David, you agree with that comment? Yes, I suppose, yes. Thank you
Sí,
very much.
totalmente de acuerdo. Inclusive el consenso colombiano recomienda que en la paciente que es obesa, definiendo obesidad como un índice de masa corporal mayor a 30, debe consumir el doble de la dosis que si no fuera obesa.
Okay, then I have received a question. Thank you. If the preparation di base found in Italy can also be administered orally or only intramuscularly? Can also be administered orally. Can also be administered orally. This is the question for Italian. Okay, then thank you, dear colleagues. We are now on 3:30. We have now the two final comments from our speakers. We started with Andrzej Milewicz, and then we had David Vàsquez. I would like to have one general comment from you on David, on your topic, not only on obesity and diabetes, but also in general, how we have to conceive now vitamin D in human health, the impact, and then how we have to face. What is your suggestion to our colleague doctors and then for their patients? And then later, David, for you mostly related to the area of fertility and of difficult fertility, both for men and women. How for infertile patients it's important to have that concept that vitamin D have a role. Now, first, Andrzej.
So the home message, which is it was some summary of my talk. That means that in all patients, if even with normal weight, I recommend to measure vitamin D. And then, so if the vitamin D is deficient, is lower than 30 nanogram per ml, you start with treatments depend of the dose what you recognize in your patient. And then, so after 1 month, if you start with treatment, please, after 6 weeks, check again vitamin D to looking for effectiveness of the treatment, because as I mentioned you before, in some people, especially not only obese but also the other people, they can have the problem with kidney and liver, which limited the effectiveness of normal vitamin D treatment, and they need the active form of vitamin D to treat. That's it.
Thank you. And then, David, your comment.
Muchas gracias, Andrea. Primero que todo, y al profesor Milewicz, he aprendido mucho de vitamina D hoy. Quiero compartir con la audiencia este libro que se llama Vitamina D más que una vitamina. Ese libro Andrea Genesani escribió el prólogo y fue publicado en América Latina y España hace tal vez unos 3 o 4 años. La vitamina D es más que una vitamina. La vitamina D es una prohormona. Necesita del cuerpo para convertirse en el metabolito activo que, como lo explicó el doctor Milewicz, es el calcitriol, y además su estructura química es más de hormona que de vitamina. Por tal razón, así debemos considerarla. Es la vitamina del sol. Y el primer día de la creación, pues no olvidemos que Dios hizo el sol precisamente, no fue por casualidad. Yo, el consejo que siempre le doy a mis colegas en América Latina es, cuando tengan una mujer al frente, no se pregunten por qué debo pedirle niveles de vitamina D, sino lo contrario. ¿Por qué no le debería pedir niveles de vitamina D? Porque realmente todos los tejidos y órganos del cuerpo humano tienen receptores de vitamina D y podemos tener la seguridad que no están de adorno, sino que ejercen alguna función, sino que en el día de hoy todavía no conocemos todas las funciones que tiene la vitamina D en las diferentes partes de la economía. Mil gracias, Andrea, mil gracias, profesor Milewicz, mil gracias a la audiencia y ofrezco disculpas por las dificultades técnicas que tuve.
Thank you very much. I think this is very important. You know, you have heard, you have listened the last words of Professor Vàsquez. Vitamin D was still existing since the creation from God of man. And vitamin D represents the importance how the sun have on the total body. And the effect of the sun is to promote and to protect the total body. When we have lack of sun, we have a lack of vitamin D, and these all the functions are reduced, either the fertility, as well many other functions of the body. Vitamin D represents the equilibrium between the inside world and the outside world. And I thank all of you for being with us again to this beautiful webinar of the International Society of Gynecological Endocrinology, and we will be together with both Andrzej Milewicz and David Vàsquez in Roma Congress, where we will have the 14th anniversary of the International Society of Gynecological Endocrinology. Please, Marion, give us the last slide of our webinar. We are at the end, and I want to thank all of you for being with us, and we will invite you to the next webinar. Marion? Next, we will, Marion? Thank you. She will, first of all, I will invite to join us 4th to 6th of March, very soon, to the 14th anniversary Congress in Roma, and and you will be also informed about the next webinars today. Thank you, Andrzej, for your beautiful presentation, and thank you, David, also to have for your fighting against the difficulties that you had to giving us your beautiful presentation. Thank you, dear colleagues. See you soon.
Bye.
See you.
Bye. Thank you.
Thank you very much.